There's been a virtual explosion of biomedical knowledge over the last century, and we're teaching different material in medical schools. However, our approach to teaching that material really hasn't changed over that time period. The foundational facts of medicine are taught in large lecture halls, the veritable sage on the stage.
I'm a big believer that human beings are in a room together, they should be interacting with each other. If you have 300 people in a room, at least in my mind, one of the worst things you could do is one person lecture to the other 299 people.
Students have little opportunity to really engage with the material, so they struggle with understanding its relevance, and they really are unprepared then for their bedside instruction when they have to take the material that they've learned and apply it to the patients that they're taking care of.
Medical school is filled with facts, but facts are fragments of knowledge. We have the opportunity in these early years of medical school to create a foundational context for these facts so that the students will be excited about combining their knowledge of biology with the diseases they will learn about in their patients. This curriculum was created to make the material come alive for the students and to inspire them to really master the knowledge they need to take care of their future patients.
Of his tracheal and bronchial epithelial cells. By engaging the students through patient stories and using the technology we have today to animate and narrate those stories.
We have the power to create these new teaching tools that really bring the basic sciences to life. We can show the preclinical medical students the links between basic microbiology and the infections they'll see in their patients.
This frees up the lecture time for truly interactive sessions, where the students work together as part of a medical team in the classroom, where they integrate the basic science foundational facts with the clinical information, skills that they will need as they enter their clinical training.
So relapsing fever with spirochetes in the blood.
Students have been involved in every step of this process. We've been working with the faculty and giving constant feedback to make sure that the material is clear, compelling, and relevant. It's really rewarding to have this opportunity to impact the education of other medical students all across the country.
2 days later, I get a call.
This also lets us bring the basic scientists into the classroom and allows the basic scientists and the clinicians to really collaborate in teaching the medical students.
The learning is more fun. The material is more engaging. It's more efficiently delivered, and it will stay with the students into their futures.
The flipped classroom in medical education, engaging students to build competency. My name is Larry Hurtubise, and this is a video abstract of an article of the same title that was published in the Journal of Medical Education and Curriculum Development. My co-authors were Alyssa Hall from the Mayo Clinic, Leah Sheridan, who works with me at the Ohio University Heritage College of Osteopathic Medicine, and Hyung Han, who works at the Southern Illinois University College of Medicine. The flipped classroom is the idea of assigning didactic materials to learners before class time while using face-to-face time for more active learning strategies. The flipped classroom is a great activity for anyone interested in curriculum development because you have to understand the backward design process, educational technology, as well as change management in order to do the flipped classroom effectively. Backward instructional design is called that because the first thing you focus on is your learning goals, what you want students to be able to do. Then you worry about assessment methods. How will you know whether or not the students can achieve those learning goals? Then your teaching methods, which should align with your learning goals and your assessment methods. And then finally, you try to leverage technology to meet the teaching methods. In today's competency-based models, learning goals are described as entrustable professional activities, or EPAs. EPAs are distinct units of work which a student can do unsupervised. Usually they're phrased in terms like manage a patient with diabetes. When you think about what it would take to manage a patient with diabetes, a student would be able to have a conversation with the patient in order to diagnose them accurately, engage in an interprofessional team dialogue to develop a treatment plan, communicate that treatment plan to the patient in a way that encourages adherence, and follow up with the patient. There are many active learning methods of assessment in medical education today. It's important to think about formative assessment in the flipped classroom so that students are assessed and get feedback on where they are and where they need to progress to. There are also many active teaching methods used in medical education today. And again, you want your teaching methods to align with your learning goals and your assessment methods. Finally, when you're thinking about technology in the flipped classroom, you can really think about this whole instructional design process as applying to the pre-learning as well as the face-to-face learning. There's technologies that are leveraged to capture a pre-recorded lecture or develop an e-learning module, as well as technologies that encourage communication, sharing, and collaboration, and assessment methods that encourage ongoing assessment and metacognition. When you think about interprofessional education today, while interprofessional care is a competency, one of the hurdles for interprofessional education is getting the students together all in one place, all at one time. The flipped classroom can be an option to overcome this hurdle because some of the class time or the instructional time can be done asynchronously. In the left-hand column of this table is a traditional TBL or team-based learning. TBL is an instructional method that's been used in medical education since the mid-90s. On the right-hand column is an example of what might be done if we add interprofessional teams. So instead of the teams just being made up of first-year medical students, they could be interprofessional teams. Technology could be leveraged to gain students' interests in order to help make those teams. Instead of using didactic materials or texts that are just for medical students, pre-recorded materials could be made that are available to all students. Instead of just doing clinical case applications, students could work in interprofessional practice-based teams to develop a practice improvement plan and present that as a case. And finally, an interprofessional panel could be engaged to not only assess the students, but give them feedback on their group projects. When you think about the change management involved with the flipped classroom model, you can think about it in terms of lectures, courses, and curriculum. Each one of those has change management implications, but they get more complex as you move up the chain. If you're thinking about just flipping one lecture, you might want to engage support teams like your technology team or your faculty development team to do a more effective job. You're going to want to communicate with your student. You're going to want to choose a lecture that's appropriate for flipping, and you're going to want to use this as an opportunity to gain experience and gather feedback from students to help you improve. You're going to want to share that feedback with others who are interested in flipping their classrooms. If you're going to flip your course, you're going to want to include all the faculty in your course. You're going to want a more comprehensive orientation where you explain to students the new model and their role and what they're going to do. Again, you're going to choose appropriate people to flip their lectures and that are more appropriate for flipping. You may have to modify your evaluations and assessment because you're using a new model to teach, but you're going to want to keep track of this and publish your outcomes. If you're flipping your curriculum, you're going to want to engage people across the continuum of medical education as well as interprofessional educators. You're going to want to include groups of faculty in making choices about which technologies to use, developing your learning goals, your teaching methods, and your assessment methods. And you're going to need to recruit, develop, and retain skills in order to support your curriculum. Finally, you're going to want to capture longitudinal data about your curriculum and publish that in international journals. Thank you.